Hey guys, welcome back to another episode of the AltMed podcast. With you as always, me, Andrew Dowling, and my co-host Mitch Kurtz. How are we, Mitch?
Howdy, as per usual.
We're pretty lucky today. We've got a repeat offender, a repeat guest. He did a fantastic podcast the first time round, and I think we're going to get just as juicy an episode this time. It's none other than Dr. Bryce Joynson. Bryce, welcome to the show.
Hey, thanks for having me back, guys. I appreciate it.
Yeah, welcome back. And for those who missed the first episode, Dr. Bryce is he's got a special interest, we'll say, or a practicing GP on the Gold Coast, but with a special interest in cannabinoid medicine and neurodivergent conditions. But because I'm just doing a quick flashback in my mind to the first episode, we talked about ADHD in quite a bit of depth, at least to my recollection. And we talked about, I think, how there was a lack of one of the telltale signs is a lack of blood flow to the frontal part of the brain, the frontal cortex. And we talked about how it was perhaps underdiagnosed. And I know there's conjecture about that. There's people who think these days it's overdiagnosed. You're at the coalface in a clinical setting. Since we last spoke, what can you tell us about your experiences with working with ADHD patients?
Yeah. Well, it's been about 18 months since we spoke last, and so much has changed in the cannabis space, and so much has changed in the ADHD space. So, man, everything has just shifted so rapidly in the terms of assessments, diagnosis, treatment options, and it's hard to keep up with it all. Even the cannabis space, I think there's about 5,500 different cannabis products I can prescribe, and that's not even including products I can get compounded from compounding pharmacies. So
Wow.
it's so incredibly vast, this area in the space. So yes, we should probably just do a quick recap of what is ADHD. So people who haven't listened to the previous podcast might be listening to this one. Go back and listen to the first one; it'll give you a bit more depth. But yeah, essentially you're right. So ADHD is a neurodevelopmental condition, and it classically presents as a lack of perfusion or blood flow getting to the frontal lobe of the brain. Now, the frontal lobe of the brain runs on four main things. So blood flow, sugar, dopamine, and adrenaline. Now, dopamine is a neurotransmitter in the brain, and we get dopamine from doing things we like doing, things that are interesting or exciting. Adrenaline is obviously adrenaline. Now, dopamine gets converted into adrenaline in the brain. So the ADHD brain does not make enough dopamine, and it doesn't transmit it properly. So if the ADHD brain doesn't get enough dopamine from an external source, it has to make adrenaline instead. So blood flow, sugar, dopamine, adrenaline. And that frontal lobe regulates our executive functions. First one is emotion regulation, just not great at regulating emotions. The next executive function is impulse control. So we're impulsive with thoughts, actions, behaviors, emotions, and dopamine seeking behavior. So example, really simple, road rage. Someone cuts you off, you get an emotion. You get angry, you get frustrated. You can't regulate that emotion. So you impulsively start yelling, screaming, driving really fast. That increases your heart rate. It increases adrenaline levels. It gets blood to the brain, and it helps you to emotionally regulate. Why didn't you just not do that? Because you couldn't regulate your emotions until you had that blood flow and adrenaline spike in your brain. Anxiety, same thing, right? Why don't you just not be anxious? You ever tried telling people that? And they go, yeah, I tried that. It didn't work. So someone without ADHD, you say, hey, man, don't worry about that. And they go, oh, you know what? I really was just worrying about that. Like, you're right. I shouldn't do that. Someone with ADHD, they go, I know I'm not supposed to be anxious, but I am. There's nothing I can do about it. Their body has an impulsive emotional response. It activates the fight or flight, the sympathetic nervous system, to increase heart rate, to increase adrenaline levels, to get blood to the brain to try and help them deal with that situation. right, to help them emotionally regulate. But it doesn't work very well. And these people live with chronic anxiety their entire lives. They get diagnosed with anxiety, generalized anxiety disorder. They get put on antidepressants, and it just never works because you're not fixing the blood flow, sugar, dopamine, or adrenaline regulation. Then everyone does dopamine seeking behavior, and that's where the cannabis comes in, right? So anything that increases blood flow, sugar, dopamine, or adrenaline in the brain. So food, sugar is the most addictive drug in the world. So food, so binge eating disorders, you eat chocolate, sugar, caffeine, nicotine, cannabis increases dopamine and adrenaline release in the brain. It does a few more things, and we'll get into that, right? Gambling, sex, drugs, porn, doing jobs you like doing, podcasting with people, it makes you feel good, right? So anything that your brain perceives as stimulating or you get dopamine from, you'll be drawn to. And then that short-term memory is that next thing. So, something in your brain for 7 seconds or longer. So that's like, getting halfway through a sentence, forgetting what you're going to say. It's walking into a room, forgetting why you're there. You're like, well, everyone does that. You're like, yeah, everyone does that. But if you do that 40 times a day, then it's a problem. That's when you get diagnosed with the ADHD, the disorder, right? Yeah. Attention deficit hyperactivity disorder, right? It's a disorder. It's affecting your life in a negative way now because you can't emotionally regulate. You're impulsive. Your memory's not very good. You can't focus. You can't concentrate. You can't task switch. You got no time management skills. All of these things are just out of whack. Your executive functioning skills are not working. That's when it's a disorder. Now, just to clarify, attention deficit hyperactivity disorder, 50% of people are never, ever hyperactive, ever. So the name is completely wrong. And what I've learned in the last 18 months is that ADHD is not even a real diagnosis in my mind. It's a cluster of symptoms. The question is, why do you have those symptoms? What is causing the lack of blood flow, the sugar dysregulation, the deficiencies in dopamine and adrenaline in your brain that are giving you these symptoms? So my job as a doctor is to figure out why you have these symptoms and go in and fix that. So that's just a quick recap of.
No, it's you spoke so well. It's such a genuinely that it's just such a valuable summary. So very, very well done. I'm curious though, because I remember when we last spoke, we talked about the prevalence, that maybe the above the standard population prevalence of people who may have been diagnosed with ADHD in athlete populations, and not to at all make light of the fact that for most people it's a disorder, but is there actually sometimes a view where you go, well, actually in certain contexts, like on a sporting field, having a brain with those levels of, blood flow, adrenaline can actually almost be like a superpower, or is that a ridiculous way to look at it?
So there are definite benefits to the ADHD brain. Now, you have to go back to evolution. You go, well, why was the ADHD brain developed? Why was it there? Why was it created? So dopamine is the drug of more. And dopamine is an essential survival skill. So there's some great books that people can go and read, Hunter in a Gatherer as well. So essentially you've got hunters and gatherers. So people that are ADHD are your hunters, right? They go out, they go seeking food, they go seeking mates, they go seeking dopamine, because you need dopamine to give you the motivation to go and do things. So if you have plenty of dopamine, you sit there and you're content with life and you don't do anything. You don't go looking for a mate to procreate. You don't go looking for food to eat because you are content. So you don't do anything. So you don't have the motivation to go out and survive. So you have the subset of people that have a lower dopamine level because it's important for survival. They go out, they hunt food, right? They're not the gatherers. They're not the farmers sitting around watering the grass, waiting for the crops to grow, right? You need those people. You absolutely do. But you also need people that go out there with their spears and hunt boars and, bring, meat in for the family, right?
Yeah.
in your females, you need females, and something innate happens in the female brain when they become pregnant and they have offspring. There is a chemical hormonal switch that goes on in the brain to make them more hypervigilant. So you'll hear a lot of females listen to this podcast and they go, oh, since I had kids, I just can't sleep properly anymore. Like my sleep patterns have gone haywire. So the ADHD brain can't switch off properly at night because it needs that dopamine and the adrenaline for it to, work properly. So when you're asleep, do you get blood flow, sugar, dopamine, or adrenaline? No, right?
Yeah.
You don't get any of those things. So how can your brain turn off? It can't. So you had a podcast the other, a couple of episodes ago talking about the default mode network.
Yes.
Yeah, right. So the default mode network is actually an ADHD thing. And so the default mode network sits in the posterior part of the brain, in the posterior occipital gyrus, and it's a network that connects to the frontal lobe. So if your frontal lobe is not working, it doesn't connect properly to your default mode network at the back part of the brain, and the default mode network is turned on when it should be turned off, and it's turned off when it should be turned on. So you have a dysregulated default mode network, which is supposed to automate your thinking process. But if you need dopamine and adrenaline and you can't get dopamine, your default mode network will automatically do things to increase adrenaline in your brain. So you know how you lie there at night and all of a sudden your brain is just going tick, 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 like a million things, and your brain cannot switch off? That's the default mode network creating adrenaline to stimulate the brain. Really tricky.
Yeah.
Is that where something like cannabis would play in, for example? But obviously acknowledging that, and you'll have to correct me if I've got this wrong, but my understanding is that something like THC, for example, interrupts REM sleep, but CBD doesn't. And how does that interplay with the upside of what some THC might do in that scenario, for example?
It is a really, really complex mechanism. And right now, we are talking complex neuropsychiatry, right? Now, I don't know how much training you guys have as neuropsychiatrists, but as a GP, I'm not trained as a neuropsychiatrist. All of the cannabis prescribers out there, I don't see any of them having neuropsychiatry, qualifications after their name. So who has trained them in ADHD and the default mode network and using high-dose psychedelic medication to reset the default mode network and the neural connectivity in people's brains, right? No one. So using high-dose THC can be incredibly dangerous. We think of cannabis as a benign sort of drug. No one dies from cannabis, right? The addiction rate of THC at the moment is above 30%. So if you are prescribed a THC cannabis flower, generally I say anything above an 18 or 20% cannabis flower, there's a 30% chance you will become addicted and dependent on that drug. Now, unfortunately, the default prescribing patterns in some of the cannabis clinics out there are set to just automatically prescribe people up to 2 grams of THC flower per day as a default.
Is that that's the ceiling, isn't it? Like, as in?
No, that's the default. So if you go through some of the prescribing systems, it defaults to 2 grams of cannabis flower per day as a default baseline prescription.
Well, I can honestly say, I think that would put me down for quite some time if I had that. Being somewhat cannabis naive, that's goodness me, that's quite a bit.
So what we've got now is we have a population in Australia. Now I'm just going to really, really quickly rattle off some statistics about Australia because we are bloody awesome. We are number 1 in the world. And would you like to know what we're number 1 in the world in?
I've got a few ideas, but I want to hear it from you.
Yeah, right.
Okay.
We have the highest rates of ADHD in the world by far. We in schools, so I've been going around asking teachers in all different schools, And approximately 30% of children in schools, in primary schools these days, are diagnosed with ADHD. 30%. The population percentage is supposed to be reported as 4 to 5%. We are 6 times that currently in our schools. You ask any teacher, oh yeah, I've got a classroom of like 25 kids and 6 of them are diagnosed with ADHD. And that's my good class. My other class, I've got 8 of them, right? And we haven't even touched the autistic diagnosis right now. So the rates of autism diagnosis have gone up 800% in the last few years.
Wow.
Yeah, so 30% of our children are diagnosed autistic and are on the National Disability Insurance Scheme, right? The NDIS.
Oh.
Now, remember, last podcast we talked about neurodiversity. So neurodiversity is talking about autistic ADHD. So everyone is on sort of the spectrum. So you're on the ADHD spectrum and you're on the autistic spectrum. So in my mind, everyone that has ADHD has some autistic traits, and everyone that has autistic traits has ADHD as well. And it just depends. And it takes a very, very experienced clinician to figure out what's ADHD, what's anxiety, what's PTSD, what's rejection sensitivity, what is actually autism. And it's very, very difficult to do that. So we have the highest rates of ADHD and autism in the world by far. We're the fattest country in the world, and we know that sugar and ADHD go hand in hand. We have the most caffeine use per capita in the world. We use the most caffeine of any country in the world. Now, caffeine is a drug and it shrinks the brain. So anything above 200 milligrams of caffeine per day, and you are causing damage to your brain. Now, you look at the rates of caffeine use in inpatient psychiatric populations, and is 11 times higher than the general population. And you see our kids walking into school drinking Red Bulls and energy drinks, and it's full of sugar and it's full of caffeine. Right, so they are damaging their brain by the overload of sugar, and they are shrinking their brain. It literally shrinks your brain and causes, worsening of ADHD because of the amount of caffeine they use. Then we have the highest rates of cannabis use per capita in the world. So we use the most cannabis. We use the most cocaine per capita in the world. We also have one of the worst diets. So 40% of our population is deficient in zinc. 60% of our population is deficient in calcium. Right? We were so bad at our diets that the government had to step in and put iodine in all of our salt. And they had to step in and put folate in all of our water. Sorry, not folate, fluoride in all of our water. And they had to step in and put folic acid, folate, in all of our flour, because we were so bad with our diet that the government had to step in and save us from ourselves. Goodness. I can keep going, but we'll be here.
I'm listening in fascination.
It's kind of, when you hear it like that, you realize, we're kind of a bit of a sick country, and I don't say that
we are the sickest country in the world by far. We have the highest rates of anxiety, depression, the highest rates of antidepressant use, one of the highest rates of suicide. We have the highest rates of vitamin D deficiency. We have the highest rates of Alzheimer's disease. And, if you want to talk to me about Alzheimer's and ADHD and the link there, we can definitely do that, right? We are in trouble as a society in Australia. We are literally living in an ADHD epidemic. And we haven't even touched on the biggest problem affecting our society, which is screens. Screen time. That is one of the biggest problems. And so remember, the brain needs dopamine, and dopamine is a drug. So the more you get, the more you need. So our 1-year-old children are being put in front of an iPad to eat their dinner, so they're quiet for the parents, so that they sit there and eat their dinner. Kids in primary school at the age of 5 have iPhones.
Yeah.
They're not even in primary school, and they've got iPhones. They've got Instagram. They've got TikTok. They've got YouTube Kids. They're addicted to it. And when you take that away from them, they go into an acute dopamine withdrawal.
Just similarly with the dopamine addiction with the constant kind of messaging, imagery, all the rest. Is there also a separate kind of issue around serotonin production with white light, looking at your phones later at night, that you would normally associate with waking up?
Yeah, absolutely. So serotonin and melatonin go hand in hand.
Yeah.
So they're in the same production pathway. So when you dysregulate the photosensitivity with exposing yourself to bright lights, it actually increases your cortisol levels. And so you dysregulate what's called your circadian rhythm. And so your brain just gets dysregulated, and it doesn't produce enough serotonin and dopamine. Now, also with diet as well, because serotonin is produced by the gut. So our diets are terrible. We've all got, horrible diets, so our guts don't work properly. So then we don't make enough of these neurotransmitters because we're not absorbing the nutrients from our gut to make the serotonin, to make the melatonin. We have the vitamin D deficiency because we don't go outside. So we're all vitamin D deficient, and you need vitamin D to regulate all of this stuff as well. So you're absolutely right. Screens are a huge problem, massive problem.
Yeah, so we're a sick country. We've got, the highest rates of some of these, neuro conditions that you're describing. We've got poor diets, over reliance upon screens and perhaps technology more broadly. And then we have a healthcare system that all these people that are, that come into contact with, and things like the NDIS. But I want to kind of ask you as a doctor, you're on the front line. You have these people from the society that we've just described here in Australia wandering in, and I think it's fair to say that it can be, and now I'm sort of throwing you the patient's perspective, it's very much a roll the dice as to the quality of care, the connection that you have with your GP, the extent of knowledge that they have about perhaps things that they prescribe to you. What are some of your observations of, I guess, the standard of healthcare as delivered by doctors for patients under their primary care?
Terrible.
I thought you were going to say that.
Terrible. What doctors have you had on this podcast that come and talk about all of these things? And talk about fixing the dopamine and regulation. We talk about cannabis and how great cannabis is. Yeah, it's a fantastic tool. It doesn't fix the problem, right? Band-aiding it. No one walks around with an amphetamine deficiency. So all these people that are prescribed Ritalin and dexamphetamine and Vyvanse, it treats the symptoms, but it doesn't fix the reason why they have these symptoms. They don't have a Ritalin deficiency. They don't have a dexamphetamine deficiency. No one has a Zoloft or a Lexapro deficiency, right?
The way it was described by some of the doctors that have been on here is that over time, depending on the condition, cannabis may or may not, but it may basically retrain your neurons to fire in a certain way that may be, I'm careful to say curative, but very much so be more on the curative pathway, call it, than just pure treatment over a period of time.
Yeah, no, Mitch, you're absolutely right. So people with ADHD do have an endocannabinoid deficiency. And that's the important distinction to make. So the reason I love cannabis or cannabinoid medicine and, reach out to you guys to talk about it and to educate other doctors and educate patients is because people don't walk around with a dexamphetamine, Ritalin, Zoloft deficiency. They do walk around with an endocannabinoid deficiency. They do walk around with a dopamine deficiency. So we know that people who have chronic pain, PTSD, trauma, ADHD, autistic spectrum disorder, they are deficient in their endocannabinoid system very commonly. And so the addition of an appropriately prescribed cannabis program under the guide of someone who knows what they're doing and is appropriately trained in this field can correct that deficiency for them and improve their symptoms. And you're right, we can start to heal some of that neurocircuitry. We can regulate those neurotransmitters and we can improve those symptoms. Absolutely. So the reason that I, am so interested in cannabinoid medicine is that my patients do have endocannabinoid deficiencies. And so sometimes I will need to use cannabis medicine to fix that. So I'm not a cannabis doctor by any means. I treat my patient. And if my patient needs some regulation of their endocannabinoid system, absolutely, I'm going to figure out what product they need, what dose they need, what delivery method they need, when they need it, how much they need. And I will work on that with my patient, but in conjunction with other medical therapies. Because when these patients, and this is speaking from a patient perspective, when my patients go to a cannabis clinic, right? They go to an online cannabis clinic or they go to an in-person cannabis clinic. The only option the doctors working at that clinic have to treat them is cannabis.
Mm.
Now that is a big, big problem, because if they say, oh, I've got pain in my back, here, have some cannabis. I've got endometriosis, here, have some cannabis. I've got anxiety, here, have some cannabis. Oh, I've got ADHD, here's some cannabis. You go, well, hang on, you're just a dispensary. You are not a cannabis doctor. You are not treating the patient. You are just dispensing them cannabis. And patients need to really be very careful when they're seeking out cannabis prescribers to know, okay, is this person actually trained as a doctor to fix me? So when I'm treating my patients, I've got to be so many different things all at once, because to treat someone effectively with cannabis medicine, you have to know everything about the condition that you're treating. And then you have to know what to do when every treatment for that condition has not worked or they have side effects. And then you need to know how cannabis medicine will work in with that condition and all of their other conditions at the same time. That is an incredibly specialized field of medicine, which should be looked after by incredibly specialized doctors. That is not the training that any doctor gets.
Is there a case to say that a lot of people who, don't have the benefit of visiting Bryce Joynson in said example, that have, potentially live rurally or just don't have, access to the best healthcare, let's say, that they may have tried a bunch of quote unquote traditional therapies and found their way to cannabis, which does tend or may alleviate, let's call it the holy trinity, as it were, right now: pain, sleep, anxiety as a starting point, which, you can find elements of in most conditions to some degree. Is there not merit in that? And on the flip side, is there not also merit in something like, I know cannabis is not considered a first-line therapy now in Australia, but given that it's, used recreationally in North America, basically, and seems to be fairly safe as a general product, especially when compared to a lot of other products we have access to. Is there not an argument on both sides to say that it's I don't want to say a benign thing to engage in, but something which doesn't cause too much concern, and understanding that if you have a serious condition, it may not be appropriate and you may need further care, and people might get the wrong impression that cannabis should just fix it, and they might require a whole host of other options. From the angle I spoke about briefly previously, does it not make sense in some ways?
Oh, it's definitely worth trying, 100%. Absolutely. So, you're right. It does help all of those things. And it's worth giving it a try and see if it is an appropriate treatment option for you if you're considering it as a patient. But then if you find it's beneficial, the doctor then needs to go, okay, why does this work when nothing else does? Because that tells me about you and about what's happening in your brain and your body. It teaches me about my patient so that I can know how to help them better. So for your patients, you go, cannabis, it's helpful. Why? Why does this work when nothing else does? So you're, okay, cool. Well, what's it doing to my brain? What's it doing to my body that my conventional treatments have not done? And let's go down that pathway, right? So the problem with cannabis is not, right, and obviously I come from an ADHD perspective where we know that smoking THC causes neurocognitive inflammation and it damages the brain and it reduces IQ and it causes permanent brain damage and it shrinks the brain and it damages your receptors at high doses used over a long period of time. We know how damaging and harmful smoking high doses of THC is, right? That is not cannabis medicine. That is smoking cannabis recreationally at high doses. Now, if you are prescribed 1-2 grams a day of a THC flower above 18%, you're not being treated with medicine. You're being given a drug and you're using drugs to treat symptoms. So it's a really fine line. And I understand there are so many people out there that do not have access to the quality of care needed to manage their medical issues, to manage their complexity of their autism, ADHD, severe anxiety, eating disorders, chronic pain issues. People do not have access to that in this country, which is very, very difficult. So cannabis can be an excellent tool for these people. You know, like I've got access on the Gold Coast, so I've got my spectral brain scanning protocol. So I use spectral CT brain scans. I'm the only doctor in Australia that does this for the, use of ADHD. There's one of me in all of Australia. I'm one of Australia's only pediatric approved cannabis prescribers in all of Australia. One of the only doctors in Australia authorized to prescribe cannabis to children. No one has access to that. No one has access to the special scans I have access to that tells me how their brain works and exactly which products to use. So I know if they need a sativa dominant, indica dominant, I know which terpene profiles are going to be good for the patient because I know how their brain works, because I can see their brain working in real time with my scanning protocols that I use. Right? I combine that with special blood tests and metabolic profiles. We haven't even talked about how hormones impact the brain and the body. Like, this is way deeper and way more complex than anyone ever thought when they set out to start prescribing cannabis. Well, I know I didn't think about that when I first started prescribing cannabis. I was like, this is great, some CBD. This is really helpful for people. It reduces inflammation. This is fantastic. And now I'm like, oh boy, it's way more than that, right? So I've had to go and do neuropsychiatry, training, endocrinology training to fix hormonal issues, bioidentical therapy, immunology. I treat a lot of Ehlers-Danlos syndrome and hypermobility spectrum disorders now, which are connective tissue disorders, which cause dysautonomia and a whole bunch of really, really complex medical problems. Like, I've got patients that have EMF hypersensitivity. So they can tell you if it's Bluetooth or Wi-Fi or cellular, right? This is the complexity of patients that I treat.
Wow. And you're treating them with a product, to the extent that you're using a cannabis flower, you're treating them with a product that may have multiple actives in it, a whole bunch of different compounds, which is going to interact with their brain chemistry. I mean, I think about, because, and the reason I bring that up is because of in the same way that we've seen the expansion of, cannabis clinicians and cannabis clinics, online telehealth, the same is true, I've noticed, for what have been dubbed ADHD clinics, people who think that you can just go and basically, and maybe you can, I don't know as much about this space, but you can call a number, speak to a doctor or a psychiatrist, and basically get diagnosed over the course of, a couple of consults with ADHD. And then for that same type of complex patient as the one that might come to your clinic, that person's just being treated perhaps with one active ingredient in their dexamphetamine or their Ritalin or something like this that can be more potentially, better dosed, let's say. And even then we read about, stimulant induced psychosis from those drugs. So I don't know what do you make of those clinics?
Absolutely. So it's important to know that having access to appropriate care is paramount. You've got people out there that have struggled their entire life with these conditions, right? And we're saying what ADHD rates are going up to 30%. So what 30% of our current population is going to be struggling with this? And how can people access pediatricians and psychiatrists? There's not enough of them. So you probably don't know that, but I'm not allowed to diagnose someone with ADHD.
Wow. Only a psychiatrist can. Is that?
I'm not allowed. I don't have the qualifications or the skills, apparently. But
Right.
a psychologist can, a pediatrician can, a psychiatrist can. But I am not able to. I'm not allowed. I do not have the qualifications, the skills, or the knowledge to diagnose someone with ADHD.
I did not know that. So all GPs across the country that would apply to, right?
Every GP across the entire country.
Wow.
And so these clinics that pop up, and there are some really, really good ones. And I work with some fantastic online psychiatry clinics, which are invaluable to my everyday practice, and some absolutely amazing psychologists who are fantastic. And they are so valuable to me every single day. Then I've got psychiatrists and pediatricians that have no training in ADHD and have no interest. And they are just there to make money off these people. They pay thousands and thousands of dollars for these assessments. Then they have a 20-minute appointment with the psychiatrist who says, yeah, sure, you've got ADHD. Here's some Ritalin, off you go.
So, and now I have to, I'm sorry, I have to touch this prickly and controversial topic because there's no rules on AltMed. Mitch and I will just go where the wind takes us. Don't we, Mitch? Sorry, I need some validation over here, please.
Yeah, we hate anything that's normal. It's probably due to our ADHD.
Yeah, exactly.
I've definitely not mentioned anything that's normal on the podcast.
Yeah, but you wouldn't actually know because you're not qualified to tell us.
Nothing about this is normal.
We are
living
totally
in an abnormal, like literally we're in an ADHD epidemic right now.
Yeah.
This is uncharted territory.
Yeah, this podcast is happening in the middle of this ADHD endemic. So yes, we've got to touch this topic because I want to ask you, in those ADHD clinics, as you say, the 20-minute consult where people pay thousands of dollars for an assessment, get their Ritalin script, are there incentive structures that sit behind prescribing habits in the same way that we have seen in medical cannabis? And I'm not going to name names. I'm not going to name, any companies or doctors, but it is, it is the case that I think a lot of patients who go to cannabis clinics have no idea about incentives that a doctor might have for prescribing a particular product over another one. It's not as though when you walk into the consult room, the doctor's has to maintain a register on the wall or on AHPRA's website that has details of disclosed conflicts where they may have arrangements with a company. What's your assessment of that psychiatry ADHD clinic space in that sense?
Yeah, so that doesn't exist in the psychiatry ADHD clinic space. So doctors, that's one of the reasons doctors are not allowed to own pharmacies, because doctors are not allowed to profit from, the prescription of medications. So the doctors are incentivized to make a diagnosis of ADHD because they get paid a lot of money to do these assessments. And, you pump out these $1,000 assessments in 20 minutes, you're making $3,000 an hour, right?
Yeah.
It's pretty good money. Now, there is no incentive for doctors to prescribe medications. to prescribe, Ritalin, dexamphetamine. There's actually a worldwide shortage of ADHD medications right now. It's impossible for patients to get their Vyvanse medication because there's just none of it around, because we can't keep up with demand with the amount of supply. So that doesn't really happen in the ADHD diagnosis space as far as I'm aware. Now, yes, people are incentivized to do assessments because they make lots of money from doing those assessments and making those diagnoses, but not for prescribing. But you're absolutely right. So what's happening in the cannabis space right now, and this is just what I am seeing, right? So this is not, I'm not making things up, but patients, unfortunately, patients are quite vulnerable. When they come and see a cannabis doctor, often they've exhausted all their treatment options. They're vulnerable. They'll try anything to help. So a lot of clinics out there, the doctors that work for those clinics have no training in cannabis medicine. And they get kickbacks for every product that they sell. So if they get you addicted to cannabis, and remember the addiction rate of cannabis is sitting at about 30% or higher. So 3 out of 10 patients you start prescribing cannabis to will become dependent and addicted to it. And the average patient will go through, let's say, 2 grams of flower per day, a 10-gram container. What's that? $140, $150 for 10 grams on average.
Yep.
So they're going through that in 5 days. And the doctor might make 10 or 15 bucks on a script. And some of the doctors even own the companies that, that they're prescribing the medicine for.
And they have a duty to, if I understand the codes of conduct that apply to the prestigious medical profession, this is coming from me, a lowly lawyer, but there is a code of conduct which requires disclosure to a patient by a doctor where there is a conflict that could compromise the doctor's care of that patient. So if a doctor proposes to prescribe, and maybe the doctor says, yeah, look, I actually, I have an arrangement with this company that makes the product that I'm prescribing to you. I actually sought them out because I noticed in my clinical experience that this product was working really well for patients. And I'm obligated to tell you that I have that arrangement before I prescribe it. And if that's a problem for you, I can prescribe you something comparable, but from a different manufacturer that I don't have any arrangement with. Now, of course, I'm giving the script that doctors, I'm sure, very rarely would provide to a patient, because I'm not, call me cynical, but I'm not entirely convinced that such disclosures actually occur during telehealth appointments. Time is money.
I don't think those words have ever been said in a medical consultation. So, I think rare would be an understatement.
So we are making a supposition that disclosures that are required to be given to patients are very likely not being given to patients, which, to your point, only reinforces the vulnerability of the patient's position, because they just simply don't have a line of sight on what is incentivizing the prescribing practices of that particular doctor.
Yeah. And remember, I'm treating a very, very vulnerable population, an ADHD population. And the more cannabis you use, the worse your ADHD gets every single time. So the more cannabis you are prescribed, the more addicted you get to it, the worse your emotional regulation, the worse your impulse control. So the more cannabis you need to fix that. It's a vicious, vicious cycle. And 30% of the population has ADHD now, apparently, right?
Yeah, that's it.
And so what's happening out there, and this is what I see every single day. Patients are going to clinics for help, and they get prescribed high-dose THC flower at higher and higher and higher doses. And they think it's helping their symptoms, because when they smoke the cannabis, their symptoms improve. And then 2 to 3 hours later, after the cannabis has worn off, they're actually worse. And that is a vicious cycle that you cannot get off that roundabout.
And I guess what's interesting is given the commercial overlay around incentive structures that sit behind the prescribing, and potentially it's an interesting word I came across not too long ago, iatrogenic, which refers to I guess medical conditions or issues that have actually been caused by a doctor or a treating healthcare practitioner. Um, but let's say to some extent that a patient's condition is iatrogenic and causal, there's a causal connection with their prescriber. I suppose what is interesting is to contemplate for a lot of people who might be naive to these types of practices that go on in these clinics, they'd be thinking, yeah, but we have regulators in this country that regulate the conduct of healthcare practitioners. And what's interesting is every time I know the TGA's, having a bit of a moment with advertising across, nicotine and cannabis at the moment, sort of flavors of the month or of the year. But I just wonder when I read about healthcare practitioners that are cautioned by APRA or have their suspension, it typically relates to inappropriate relationships with patients and these sorts of things, but you never really see doctors reprimanded for conflicts. Um, is there anyone that's sort of policing conflicts across prescribers, or am I just kind of in a delusional fantasy when I even utter those words?
Look, if anyone listening to this podcast knows the answer to that question, I'm sure they can write into the show and let you know. Uh, at the end of the day, my job, I sit at, the patient level and treating my patients and looking after my patients and advocating for my patients. So I get so upset when I see my patients receiving suboptimal care, or I hear about people receiving suboptimal care, and whether that's through just general medical care, whether that's from their pediatrician or psychiatrist for their neurodiverse conditions, whether that's from medicinal cannabis clinics where they're just not being looked after properly. You
Mm,
know, that, really upsets me, and it drives me and gives me the passion to do what I do and, work as hard as I work to try and improve things for my patients. Just
yeah,
for some context, I did a quick audit of my prescribing practices, and only 20% of my patients I prescribe a cannabis flower to.
right. Yeah, so it's a tool in your kit, but it's not the be all and end all. Whereas at certain clinics that you go to, like that's it. You're there to get cannabis, and you fill in the questionnaire in a way that the questionnaire almost leads you to fill it in if that's what you're seeking access to.
Well, yes,
Yeah, yeah,
I've tested those clinics myself because, I firmly believe that as a doctor, you should not prescribe anything to your patients that you are not willing to take yourself.
yeah,
I would not ever prescribe my patients a medication that I would not be willing to take myself. Right?
yeah,
That's a pretty bold statement
yeah,
because if I'm saying, hey, take this antidepressant, patients going, oh, okay. Would you
yeah,
take it? No way. I wouldn't touch that. No
yeah,
way I would go on that antipsychotic. No way I would do that.
yeah,
If you as a doctor would not take something yourself, why are you prescribing that to your patient?
yeah, yeah. That's no, exactly. That is such a simple but I think effective way that more doctors should be thinking about the way that they conduct their clinical practice. It's so true. And yeah, sorry, I'm just thinking about some of these questionnaires I've come across. I did one the other day.
Yeah.
What is your name? I typed in Andrew. So do you have a medical condition? I selected no. It said, do you want access to medical cannabis? I selected no. And it said, congratulations, you're eligible.
No.
It's
I did a questionnaire one time, and then I got in and I got through the process, and I had the phone call with the doctor, and they said, oh, what's going on? And I said, oh, I got some anxiety. And they said, okay, well, what would you like to try? I was like, hang on a minute. You're the doctor. Like, ask me my symptoms. Ask me what's going on. Ask me what's happening in my life. Ask me, like, you tell me. You're the doctor. I am not medical. I don't know anything. I'm coming to you for help. Why are you asking me what I would like to try? That's
Yeah.
not how this works.
Yeah.
Right?
And it's no,
And,
totally. Yeah.
and did you want to try flour with that as well? Like that was literally the thing. Oh, do you want a script for flour as well, just in case?
Yeah.
Like it was a add on. It was like, would you like this as well? And I'm like, what do you mean? Would I like this as well?
Can we get you a fentanyl patch on your way out? As no, like yeah, it's a
It's,
lot,
it's
and
upselling, right? Like,
it
it's
is
trying to
upselling.
upsell me. Would you like some weed with your prescription? Like, no,
Or it's
I would
yeah.
not.
In yeah, no, it's so but the thing is, I suppose as well, I as much as cannabis gets this name for, the number of cowboys that are in this industry that may be conducting their business unscrupulously, it is an issue that affects the medical community more broadly than that. I mean, because if you took away the ability for pharmaceutical companies to pay doctors, who's going to fund doctors to speak at, a pain conference, right? Like there's all these ways in which companies seem to find novel ways to incentivize prescribing of their products. And it isn't just cannabis, but I guess because
Mm,
all three of us have had contact with that particular
that's right.
industry, we see it, but it is just a bigger picture. And I don't yet know. I have, kind of floated in my head with the idea that should doctors just have on their ARPA registration a constant, updated conflict register. But then I think, well, who would check that as a patient? I mean, I would because I'm a bit of a nerd and that would interest me. But
Yeah.
yeah, it's
Yeah,
just
patients are looking for help.
yeah,
So we just remember that patients come and see me. They just want help. They want me to help them. They want to feel better. And so if someone is promising them a solution, say, here, look, yeah, take this cannabis, it'll make you feel better, they're going to do it. They don't care if the person has a conflict of interest or, they don't understand what all of those letters after a doctor's name actually mean. You
mm,
know, patients are just looking for help and they want to feel better. And we need to remember that at the end of the day, our job as a doctor is to look after your patient and do no harm. So,
yep,
you know, you have to make sure you're not doing any harm to your patients with anything that you're prescribing. So remember, you mentioned the Ritalin-induced manic psychotic episode from this patient. And, I see that every day in my clinical practice where I do brain scans of people and I see that their brain is very hyperactive, overstimulated. And I say, no, I am not prescribing you a stimulant because I know that it will not go well for you. I had a
yeah,
young girl who had a very overactive type brain, and the pediatrician had prescribed them a Ritalin derivative. And I said, don't do it. It's not a good idea. They're like, but she needs to focus in school. And I said, look, if you wanted to try this, I do not think it's a good idea. I don't think it will work. Do it at home when you can monitor her and see how she responds. And within 15 minutes, she picked up a table and threw it through a window. And then she spent the next 6 hours hiding in her closet in a dark room for the next 6 hours.
yeah. That is,
One tablet. And I was like, oh, I don't want to say I told you so, but
but I kind of told you so. No, that is, yeah,
but
that's
I can tell that with my technique and my experience, I can tell how people are going to respond to medications like 99% of the time before I prescribe it.
yeah,
No other doctor in Australia is doing this. Like I'm going to get, audited after this podcast. I'm going to get audited by Medicare and by APRA because I'm the 0.01%. I'm the one doctor in Australia doing this. No
The
one else is
Upper and
doing this.
TGA watch regular subscribers to the
yeah.
podcast.
Big shout
I'm
out to
sure
APRA, TGA, Departments of Health and Aged Care, all the
you are
yeah.
doing a wonderful job, and we appreciate you looking
We love
after
it. This
everyone.
is
And
all the criticism we've said is entirely about the private sector. No, yeah, you guys are
we've
the
not actually said any criticism about the regulatory bodies, just that the regulatory bodies need to look after patients, and that is their job. The regulatory bodies are there to look after patients. And if all of these things are going on, and we know they're going on, you know they're going on, all the doctors know they're going on, all the cannabis companies know they're going on, why hasn't the regulatory body stepped in and done something about it?
Yeah.
Right?
And
that is their job, to protect patients.
Absolutely. And that, you know, there's, yeah, it's like, yeah, it's a whole other podcast episode, but
yeah. Anyway, we should probably finish up.
We should.
All night, right?
But Bryce, I think what we've at least established is that there is a very good case to have you on a third time at some point. We will space it out. We might not go a full 18 months until the next one, because it is always a pleasure chatting with you. But it's just, yeah, every time we start, I'm like, oh, we
haven't even scratched the surface of like, obviously we've got a medicinal cannabis flavor to the podcast for this, but we haven't even scratched the surface of understanding anything about neurodiversity in this podcast today. We haven't even scratched the surface of treating ADHD or with cannabis therapies. You know, we haven't even touched on that even for half a second, and that's an hour-long podcast in itself.
Yeah,
just on any one of those topics.
Yeah, autism, Asperger's. I would really love to
epilepsy, like traumatic brain injuries, Peter. Anyway, I need to make my own podcast, so I'll probably
you do. In fact,
do that at some point, right?
I've got a feeling at some point that might just happen. But no, Bryce, thank you so much for your time and for your insights. We basically we can't do this podcast without the time of our guests, and to just be able to download everything that you're seeing and your observations, just totally invaluable to us and to our audience. So thank you so much for that. We really appreciate it.
Not a problem at all. And I always will say that these are my observations. These are my treatment protocols. These are my patients that I'm seeing and treating on the ground level. The statistics that I'm throwing out, you won't find any of these statistics in the current literature, because this is what I am seeing. So the statistics are too far behind. The statistics that are coming out are from last year, from the year before, from the year before that. Look how much has changed since we spoke in 18 months.
Right?
Actually. So everything that I'm seeing is real world, keeping up to date with what is actually happening right now. And it changes so rapidly. So yeah, it's an interesting space for patients listening out there.
We'll be at 50% ADHD diagnosis for the Australian population when we next speak. So
at least.
No, Bryce, thank you so much. We look forward to the next one, and keep doing what you do, because it's invaluable for your patients and for the broader community.
Yeah, thanks for having me on, guys. I really appreciate it.
Of course, mate. Anytime. We'll have to do it again probably before 18 months away, I'd say.
Yeah,
just to find out about neurodiversity.
Sounds like a plan.
All right.
Thanks.
Next time. Take care. Thanks, Bryce.
Cheers, Bryce.
Cheers.